AIS for this session, and I'll be talking about the glaucoma drainage devices, essentially a video-assisted program. So I'll be showing more videos, less theory. Uh, Glaucoma drainage devices we know are very frequently used, especially in cases which are refractive to, where the IOP control is very difficult, and especially when a surgery has already failed. Particularly patients like NVG or uveitis patients and failed trabs, and if there's a lot of scarring. So these are the kind of cases who will need a glaucoma drainage device. So we have two types of drainage devices, valved and non-valved. Both are available to us in India. This technique is essentially the same with some difference. So how they work is basically that you have a tube which drains the aqueous from the anterior chamber into the subcutaneous space where you have a reservoir, and a capsule is formed around the plate of the implant, and from where the aqueous goes out and the IOP is controlled. So essentially, I'll take you through the steps. This is an NVG which has been lasered and now well controlled. We are doing a primary tube for this patient. So what we do is you open up the one quadrant, usually a spherotemporal quadrant, and uh, I like to open at the limbus, but you could go a few millimeters behind as well. Give a little radial incision in the spirally as well as the temporal side, so that the access is easy. And you can see the line of the intermuscular line is very clear, and beyond that the sclera is very little avascular and white. And the important thing is to dissect the subtenon space as neatly as possible without shredding the tenon's capsule. And the next important step is to prime the implant. This is very important in case of AGV. Basically, what it means is that you cannulate the tube of the implant and push some VSS through it. And once you can see the VSS coming through the implant, the valve area, your device is ready to be done. The opening pressure, the first time opening pressure of the implant is very high. So if you forget this step, then this valve is not going to function. The next, you have to suture the implant to the sclera, and you have exposed it nicely. If you need help, you can use some muscle hooks to retract. By and large, most of the time, we don't really need anything. So I like to put some pre-placed sutures, usually 10 millimeters from the limbus, somewhere between 8 to 10, but I prefer to be on the upper side. And once the pre-placed sutures are put there, then you know where implant is going to go exactly. You can use any non-absorbable suture. Most people use 80 or 70 Prolene, but I prefer to use this Dacron sutures 50 or 60. This is because of the needle, basically, because this needle is spatulated side cutting needle, which is specially designed for passing suture in the sclera. So that minimizes the risk of scleral perforation, and that's the reason I prefer this one. And once it is done, basically, once the implant body is sutured to the sclera, you have to push this tube into the anterior chamber. Now, this is an important step, and the care should be taken at this step. So what I do is I usually use a 23G needle and go one wavelength, which would be like 2.5 millimeters behind the limbus. And then you go intrasclerally for about 2 to 2.5 millimeters till you have reached that point. And then you turn your needle inwards towards the center of the pupil. And also I like to turn it a little bit sidewards to give a little curved kind of track. So once that happens, and when you're coming out, once you have an anterior chamber now, and just make sure that you don't make a very wide track, but enough to push the tube. And then you come out, make a little side cut. Now that makes a slight funnel there at the opening, and the the pushing the tube to that area becomes easy because the rest of the tunnel is very narrow. So it takes a little patience here. But with patience, you can gradually push the tube into that tunnel. You notice that I haven't injected anything in the anterior chamber, and the AC never collapsed. So most of the time, that's what happens. You don't need to inject any viscoelastic in the anterior chamber. But if there's a difficulty, then you can inject some in the tunnel. So you can see, once you can see the tube is there in the anterior chamber, and you see a good amount of, good length of tube is there, which should be about 2 millimeters or 2.5 millimeters in the anterior chamber. And should be between the cornea and the iris without touching any of these structures. So once that is done, the next step is to cover this tube basically with some kind of a tissue patch graft. I use a donor sclera from the eye bank, but you could use facial lata or some other commercially available structure as well. Nowadays, if the tube is longer, so you have made a 3 millimeter in a tunnel with a needle, intraocular tunnel, then some people advocate that maybe that the patch graft may not be needed. But I like to put it because this gives you extra, layer of safety. The most important complication here that we want to avoid is the erosion of the tissue over the tube, because tube is a foreign material, and sometimes the erosion of the conjunctiva can happen, and that would lead to exposure of the tube and risk for endophthalmitis. Once the patch is put, pull the tenon and the conjunctiva together over the patch graft. Make sure that both the layers are pulled over, and the tenon capsule should not lag behind, which is important. And once this is done, you just suture it to the limbus and to get a nice closure so that there's no part of it is exposed. RD is slightly different, more or less the same, but it's a little bigger implant, and the wings of the RD, they have to go under the muscle. And also the tube has to be ligated, because this is a non-valve device, so the tube must be ligated. So this is a juvenile rheumatoid arthritis patient who had undergone multiple surgeries. The AC is very shallow, but you have an intraocular lens. So similar, the exposure is more or less similarly. Again, I'll put some pre-placed sutures there. And once the implant is inserted in place, tie the plate in place with the sutures. The wings have to go under the muscles, and once the suture is when the plate is sutured, the next step is to ligate this tube basically. So now this is 60 Vicryl I'm using. The tube has to be ligated, so and checked by pushing the tube BSS through the tube so that it doesn't allow any fluid to go over the implant. So this will prevent early postoperative hypertonic because there's no valve in this tube. And the rest of the procedure is more or less the same, that you have a long needle tunnel. Here the AC is very shallow, so I put the tube behind the iris into the sulcus. So these are some of the publications we have managed. So basically, these valves are quite effective in complicated situations. And in a short-term basis, you can see whether it's ADI or AGV, all these patients are complicated, refractory patients. And you can see in 3 to 6 months time, both ADI and AGV, they give you almost similar IOP lowering, which is significant from the preoperative value. And this was a study from where AGV and ADI were put in the post-penetrating keratoplasty patients. And again, you can see even in post-penetrating keratoplasty patients, the IOP control is more or less similar in both these groups, at least on a short-term basis. If you look at the overall success rate of these implants, they do reduce IOP significantly, because all these patients most of them are actually, they have a high baseline IOP. So you can see over 50% reduction in IOP. And also the success rate overall would be somewhere around, around 70% in 3 to 5 years time. So that's a good success rate for most of these cases who are otherwise very poor risk for for surgery. So to summarize, glaucoma implants have an important role to play in lowering intraocular pressure. They are very useful in complicated situations, and the GDD, they irrespective of their design, they tend to give almost more or less similar IOP control. Some differences, of course, the smaller valve will give you a little higher pressures, and the larger surface area will give you a lower pressure. But over a period of time, So thank you very much for once again AIOS for this opportunity. I close my session. Thank you.